Welcome to everybody who is joining us today. My name's Jamie Schrant. I'm an outreach manager with Rogers Behavioral Health, and I'm your moderator for today's webinar. The webinar today is entitled Evidence-Based Psychological and Pharmacological Interventions for Perinatal Mood and Anxiety Disorders. Joining me today are Dr. Ajeng Puspitasari. She's our clinical director at Rogers Behavioral Health's Twin Cities location. We have 2 locations there in the Twin Cities. And then also Dr. Hemalatha Rajanna. She's the director of Adult Inpatient Care and Focused Depression Recovery Adult Residential Care at Rogers Behavioral Health in West Allis, Wisconsin. Welcome to you both. Next, just before we get started, I want to give all of you just a few quick overviews of the format for today. The webinar is scheduled for 90 minutes, and to receive CE credits, you must be logged into the webinar for the entire program. A PDF of the PowerPoint slides and list of references will be available immediately after the program via an email link to your personal dashboard on ce-go.com. In addition, a recording of this webinar will be published on the resources section of our website within the next day or 2 for all of you to rewatch. Our speakers will be giving a 70 to 75-minute presentation. Following the presentation, I will facilitate a Q&A session. During the presentation, we just ask that you refrain from using the chat feature, as it is a distraction for the presenters and other participants. But if you would like to ask our speakers a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you'll be able to see where you can simply click on the Q&A button on the Zoom task board. I will review all of the questions that you're submitting, and then the presenters will address them during the Q&A portion of the webinar. Okay, and so then finally, we have enabled closed captioning for this program. At the bottom of your screen, there is a live transcription button. From that menu, you can click Show Subtitles to view the audio as text if you would like. If you'd like to disable those subtitles, simply click Hide Subtitles from the live transcription menu. So, without further ado, I'm going to turn it over to our presenters. Thank you to both of you for.
Thank you, Jamie. Good Friday afternoon, all. It's been a pleasure to be here to facilitate this presentation with my dear colleague, Dr. Rajanna. To start this presentation, I just want to mention that there is no financial disclosure for this presentation. And here are the 3 core learning objectives that we will discuss in more details throughout the presentation today. And here are just some more specific points for each learning objective that we will go through in more details. We will end the presentation with about 30 minutes of moderated Q&A for more discussions. So I'm going to kick off this presentation and start by discussing some of the socioeconomic burden of perinatal mood and anxiety disorder. I want to start by sharing this biography by Brooke Shields. She is a celebrity who wrote this book called Down Came the Rain. In one section of the book, I thought really pictured what perinatal mood and anxiety disorder looks like and how it's experienced by many parents. So I'll read what she wrote in the book. She said, "At first, I thought what I was feeling was just exhaustion, but with it came an overriding sense of panic that I had never felt before. Rowan kept crying, and I began to dread the moment when Chris would bring her back to me. I started to experience a sick sensation in my stomach It was as if a vice were tightening around my chest. Instead of the nervous anxiety that often accompanies panic, a feeling of devastation overcame me. I hardly moved. Sitting on my bed, I let out a deep, slow, guttural wail. I wasn't simply emotional or weepy. So I thought this paragraph is very powerful because she also illustrated some complexities of perinatal mood and anxiety disorders that really differentiates between the quote normal or common challenges and big emotions that many mothers and parents feel during the perinatal period. And we'll talk a lot more about that, how we differentiate the many challenges and big emotions that are commonly experienced and when then it starts to morph more into perinatal mood and anxiety disorder. So just to level set and so we are all on the same page, I want to start by defining what do we mean by PMAD. So perinatal mood and anxiety disorder includes depression and anxiety disorders during pregnancy and 1 year postpartum. So a few things that I want to point out here is that in the past, the literature has focused probably more on the perinatal or even postpartum depression side, which is depressive episodes that occur after birth. And common or more recent research has now looked into more of the comorbidities since there are actually more studies documenting that anxiety and anxiety disorders are also commonly reported during the perinatal period, and that the comorbidities between depression and anxiety is very high. So more recent literatures focus on combining both perinatal mood and anxiety disorder, which will be the focus of our talk today. So I want to start with this case example. I'm not going to read all of the blurb here, but I just want to use this case example of Charlie, who is a 32-year-old cisgender heterosexual white partner woman. She was 3 months postpartum with her first daughter, Skylar. And we're going to use the same case example throughout as we go through in this presentation. But a few things that I want to mention are some of the things that Charlie experiences, such as big, difficult, intrusive thoughts, such as I'm failing as a mother. What if my baby stops breathing throughout the night, and what if my baby gets sick? So just want to start by giving this case example. And now I'm going to move to briefly summarize what we know so far in terms of the prevalence of PMAD. So this study that was published in 2020 looked at the prevalence of PMAD and serious mental illness between 2006 and 2015 among women in the United States. And I want to start by pointing you to the first part of this graph, where it shows that depression and anxiety has increased between 2006 to 2015, has increased from 18.4 in 2006 to 40% in 2015. Similarly, for serious mental illness on the right side of the graph, when we talk about SMI in this study, they included symptoms such as psychosis and bipolar disorder. They also found that there was a increase between 2006 and 2015, where the prevalence was about 4.2 in 2006. And increased to 8.1 in 2015. So a very important study to know and what demonstrate that this is one of the conditions that should receive more attention from behavioral health services and other healthcare fields. So what are some of the impacts of PMAD? This study in 2016 by Luca and colleague, they captured really a lot of numbers and statistics from the impact of PMAD. They did concluded that PMADs are the #1 complication of both pregnancy and childbirth, and that it affects up to 1 in 7 pregnant and postpartum individuals in the United States. I think what is very important to highlight that they estimated that the total cost for untreated PMAD was about $14.2 billion for all births only in 2017. And this economic burden or financial cost comes from the productivity losses of the parents who are not able to either work or experience a lot of absences in their job. There has also been an increase in maternal health expenditures, whether it's during the delivery or postpartum, where parents then need to access more health care when they experience PMAD. There is a cost from preterm birth of $3.3 billion. And then what's interesting is PMAD, when it's untreated, also impacts the development of the babies and children. So this graph or this figure includes more specifics on their conceptual model of the economic burden or societal burden of PMAD. And as you can see, they split it between the cost that's coming from the mother with higher work absences and presenteeism, lower labor force participation, increased likelihood of suicide, and then increased risk of worse mental health and other general health, which then leads to more income loss and reduced economic output. And at the same time, as I mentioned earlier, there's also costs from the babies or the children's end of the spectrum. Here they specify that there's more increased risk of low birth and preterm birth, higher risk of SIDS or sudden infant death syndrome, and then more challenges with behavioral and developmental disorders, which then also leads to increased healthcare costs. So here are just some of the points that I've mentioned before. One thing that I want to highlight here, not only that PMAD may increase the risk of suicidal behaviors, it may also increase the risk of infanticide, poor attachment with a baby, and then association with child's emotional and behavioral difficulties. Another summary of a study in 2012, where they look at the impact of, in this study, only postpartum depression for a diverse group of parents and individuals. So you could see here that for adolescents, the rate is pretty high, about 61%, which I'll discuss more. They also break it down into other subcategories or subpopulations, such as immigrant women who came to the United States, fathers, and then they also broke it down based on ethnic and racial identities, which we'll also cover a little bit more in detail. So PMAD among adolescents, I think, is one area that is important and should receive our attention. Here we learned that PMAD or postpartum depression affects up to 61% of adolescents compared to perinatal adults. And the hypothesis is that there are a lot of compounding stressors that many teens experience when they go through perinatal period during adolescence period. They may struggle with more social isolation and lack of social support. Because they themselves are still developing. It's an important part of development during adolescence. They might experience more parenting stress, and also more physical, emotional, and financial demands of parenting. Some teens may have to alter or give up some of their vocational or educational aspirations due to parenting. And difficulties attachment with babies may also contribute to this higher rate of PMAD among adolescents. More attention should also be given to how PMAD among adolescents influence or contributes to more suicidal behaviors and substance use. This study also talked about how PMAD can affect immigrant women differentially. I just want to start by saying that there is very limited research that looked into how PMAD is experienced by those who immigrated, for example, to the United States from other countries. Some of the potential challenges related to navigating immigration status, in addition to the stress of parenting and childbirth, race and ethnicity and cultural differences. Some who immigrated to a different country, they might not have connection or limited support from their extended family who are not staying in the same country. There may also be differences in how women and parents express psychological and psychiatric disorders. Depression may not be something that is part of their cultural jargon or language that they use to describe difficult emotions that they experience. Another potential stressor is those who immigrated to a new country might also have to navigate parenting and childbirth with not having established social network, vocational stressors, unstable housing. The last thing that this article discusses is the importance for clinicians to understand not just the current stressor after migration, but the type of stressors that might occur before somebody comes to a new country or any other traumatic events that might happen pre-migration. Here is also another area that hopefully will get more and more attention is the experience of anxiety and depression among partners and fathers. So it's very interesting to know that some studies did document that there is an increase in the prevalence of depression and anxiety among partners and fathers. The prevalence currently is about 10.4%. And one of the recommendations that should be considered is to also monitor and assess PMAD symptoms among partners using established measure, such as the EPDS partner. More emerging studies also indicated that maternal depression, not only PMAD that affects mothers or those who go through the perinatal period, can impact negatively on the children's behavioral problems and emotional development as well. Another area that we want to highlight here is how PMAD may differentially affect Black, Indigenous, and people of color. Statistically, the current studies indicated that depression, postpartum depression, impacted mostly to Native American, whites, Blacks, and Latine. And that we all know from the general literature that treatment engagement and access to behavioral health treatment can be more limited for those who identify as Black, Indigenous, and people of color. And this is highlighting the importance again for screening for PMAD during perinatal period for this population. This is another emerging area that now research is still very limited, but there has been some qualitative study to show how or to examine how PMAD impact transgender individuals during perinatal period. This one qualitative study summarized that those who identify as transgender and went through perinatal period reported significant and persistent loneliness. That the process of navigating identity-related stress, as well as pregnancy and childbirth, also that compounding effect can increases more stress. The fact that there is no clear role models of what is a positive, well-integrated gender variant role might look like, and then the conflict between gender identity and social norm, as well as managing this conflict or tension regarding other perceptions and how to navigate healthcare environments, which unfortunately often where a lot of more stressors can occur when the environment is not gender affirming. So I'm going to move to the next section of our presentation where we're going to summarize some of the common diagnoses within the umbrella of PMAD and the psychological and pharmacological interventions that we will discuss today. So we'll start with perinatal depression, where I mentioned earlier that the literature is more advanced in this area. We focus more on pre and postnatal depression in the past. And when we talk about perinatal depression, it includes the same criteria that major depressive disorder has outside of the perinatal period. So this may include at least one of the first two, which is persistent sadness, empty mood, and or significant loss of interest and pleasurables in doing activities, irritability, and increased sense of anger might also been reported, mostly feeling guilty and worthlessness and hopelessness towards the future, more fatigue and restless, difficulty concentrating, sleeping, and then significant changes in appetite, weight, or both, and then also thoughts about suicide. So some considerations to note for perinatal depression specifically. Perinatal depression prevalence range from 6.5% to 12.9% in the study in 2005. I mentioned earlier that there is a high comorbidity between depression and perinatal anxiety. And one thing that is going to be a theme throughout is that some of the symptoms may also are symptoms that pregnant women or perinatal women and individuals report in general, such as low energy, fatigue, changes in appetite and weight, and also changes in sleeping. Now we move to panic disorders, but one thing that I also want to mention, what we're not covering a lot in depth today is perinatal bipolar disorder, but I just want to mention that that is typically lumped into the perinatal serious mental illness category. So panic disorder is a type of anxiety disorder where individuals report an intense fear and abrupt onset of physical symptoms, including shortness of breath, racing heart rate, and dizziness. And then usually it is followed by this anticipatory worry or anxiety that more attacks will happen in the future. Some people also report that they extremely are fearful of the consequences of having another attack, whether it means that they're having a heart attack or that they're dying. Often, those who experience panic disorder will have a change in their behavior, such as avoidance. They may start avoiding attending events or going to places where they know that they cannot easily leave the situation, such as churches or being in the elevator. So avoidance often is a really big part of anxiety, or sorry, panic disorders. The prevalence rate for panic disorder is around 2% during pregnancy and between 1.4 to 2.7% postpartum. One thing that I want to highlight looking at the symptoms of panic disorders is that there may be a possibility to misinterpret these physiological symptoms from significant medical event. And then pregnancy on its own may increase the recurrence of panic attack for those with history of panic disorder. All right, now I'm going to switch to my colleague, Dr. Rajanna, who will go over the next few slides.
Thank you, Dr. Puspitasari. So I'm going to talk about few of the diagnoses that we experience in pregnant ladies, one of which is obsessive compulsive disorder. Obviously, the symptoms of this particular disorder is that people experience unwanted intrusive thoughts, ideas, images, doubts, and impulses that actually invoke some anxiety in them. They have these repetitive thoughts and they can't control them. In turn, what happens is that they start to neutralize that anxiety or the intrusive thought with other behaviors, like the compulsive behaviors that they tend to kind of utilize, like counting or cleaning or washing. They tend to kind of use this to cope with their excessive anxiety. Next slide. So what we look at here is the prevalence of the illness itself is like in the postpartum is about 2.7. We tend to also notice that individuals and partners generally experience subclinical obsessions postpartum. They have had a new baby, they're anxious about how to maintain the cleanliness, infections, things like that. So that already kind of elevates the subclinical obsessions for them. And could also tend to cause the OCD traits in those parents is one way of looking at it. And the other aspect is someone who already struggles with OCD symptoms might kind of exaggerate or exacerbate their symptoms during this time frame, whether it is prenatal or postpartum. Next slide. So what are we looking at? I think the concerning thing about this is because there is a baby involved, and that the fear of losing the baby is something that the mother or parents, for that matter, struggle with. So they constantly have this fear that the baby might die due to sudden infant death syndrome, SIDS, which we all know. They also worry about harming the baby, by doing something that they're not supposed to do, and they tend to worry that they might hurt the baby in a certain way. They're constantly worried of baby getting contaminated, having excessive need to check on the baby, like constantly checking whether the baby is sleeping, whether the baby is breathing, if there's a rash on the body and things like that, that parents tend to constantly check on. Increased reassurance seeking, I think that becomes a significant issue, especially with the first mothers or first parents, for that matter, that am I doing the right thing? Am I doing something that I'm not supposed to do? And that reassurance seeking becomes constant and sometimes exhausting for parents, and for that matter, probably the family. They also tend to avoid caring for the baby because they are scared about they doing something not right or wrong that might hurt the baby in a certain way. So these are some of the OCD symptoms that kind of becomes more prominent postpartum that we tend to see. Next slide. With regards to OCD per se, like I said, as much as OCD itself involves, worrying about harming the baby, and we don't particularly see hallucinations or delusions in OCD, but those are the symptoms that we tend to see in psychosis per se, like patients might hear voices, or they might have specific delusions, some bizarre behaviors that they tend to kind of develop during that time frame, having that mood lability, feeling either too sad or too happy, or not having that control over that happiness, and the mood fluctuation, sometimes agitation, and confusion, not knowing what to do. Those are the symptoms that as patients might experience in that psychotic stage if they're experiencing one. Psychosis also involves the egosyntonic ideation, like they're not quite sure, like, as to is it me? Is it my baby? There is that question that comes into picture as well for them. And then they start worrying about, they probably start thinking about wanting to hurt the baby, or thinking that I need to do this to help the baby in a certain way. So there is that, the egosyntonic ideation that starts developing. With regards to the OCDs, though, these are more intrusive thoughts, and to help those thoughts, that tend to develop some of the coping mechanisms, and they do some repetitive things which in turn might damage themselves or their baby. Next slide. PTSD is another very important illness that women struggle with. Women tend to have post-traumatic stress prior to becoming pregnant. They might already be struggling with the symptoms. Symptoms that people will be struggling with would be due to an intense distress that might have happened to the subject, to the person, or because they witnessed something that was life-threatening, that they start having some of the symptoms. The main ones that we look at are re-experiencing those events. If they're sleeping, they have nightmares. If they're awake, they have flashbacks. Avoidance of anything that might elicit those memories for them. So avoiding going to places, or being in certain events, things like that, avoiding those situations, or that they're constantly hyper arousal, like they're worried and fearful that something might happen in the next minute. So they're constantly worried about that. So those are the main symptoms that people with PTSD would be experiencing already. And that pregnancy itself might exacerbate these symptoms. If you want to move to the next slide, Dr. Puspitasari, thank you. That the prevalence of this ranges from in perinatal period, it's about 1.7% to 8.1%, and in postpartum, it's from 1.5 to 2.8% increase in the symptoms itself. So like I said, if they have had PTSD symptoms from before, that exaggerates itself. And there is also some mothers who suffer from having a very complicated pregnancy, or even the labor that kind of happens to be fourth degree and things like that, which becomes extremely traumatic to the mothers, that they tend to develop the traumatic stress disorder later. So those are some of the things that women also experience during and after pregnancy. Next slide. You can take over.
Hey, thank you, Dr. Rajanna. So the next anxiety disorder that we're going to discuss is GAD, or generalized anxiety disorder. And this disorder includes this excessive and uncontrollable worry for more than half the days for 6 months or longer. With GAD, the worry, the content of the worry could include a lot of different themes. It might be parenting concerns that she's not a good enough mother. It may be worrying about the child's health. It might be worrying about financial stressors. And often GAD is accompanied by many physical symptoms such as restlessness, irritability, and muscle tension. The prevalence for GAD is around 8.2% among perinatal populations. And this may be contributed by a lot of multiple life domains changes, including adjusting to the work environment after parental leave, changes in relationship as partners after having a baby. Social support may also look different during the perinatal period. And again, financial stressors can definitely increase once a baby is coming. Now, it's also very important because any new parent, it's very understandable and normal to have an increased worry in multiple of these life domains. One thing that we want to keep in mind as clinicians if this constant worry starts to really interfere significantly in their functioning. So it maybe paralyzes them and they're unable to even fall asleep or stay asleep. They're unable to do their functional day-to-day responsibilities or hygiene. So that's when we want to start considering connecting them with more resources and treatment. Social anxiety is another area where it is related to marked distress in social situations or performance situations, mainly usually because of being embarrassed or negatively judged by others. With social anxiety, people often then starts avoiding any social situation or interaction, or even when they are able to attend some social environment, they will have to endure that situation with very, very high distress and anxiety. Similar to other anxiety disorders, social anxiety also often has the avoidance component, where parents may start avoiding going to parent groups or family gathering, or no longer get in touch with their friends or social circles because they're afraid to be judged. The prevalence for perinatal social anxiety or social phobia is around 4.1%. One thing to keep in mind is many parents may have a significant change in their social activities and not always necessarily due to social anxiety. As we all can imagine, that having a baby really influence our ability to engage in many other social engagements. So maybe going to the gym in the morning or joining a book club was something that somebody used to do in the past, but with a change in schedule and nursing schedule, then it may change their social activities as well. So it's very important to differentiate between social anxiety and just social changes that are due to parenting. Diagnosis of social anxiety should be made if the person reports avoidance of social situation that is mainly due to fear of criticism and or being embarrassed. So here's another area where it will be important for us to discuss, which is differentiating between baby blues versus PMAD. So postpartum baby blues affects a really high number of new parents. So about 80% of postpartum individuals reported experiencing baby blues. And baby blues usually in terms of time frame occurs around for about 2 to 3 days after birth and lasts around 2 weeks, so a shorter period of time. That includes this feeling of overwhelmed, tearful, exhausted, hypomanic, or irritable. One thing to point out is that baby blues often resolve naturally, that parents report feeling better after a couple of weeks without further intervention. So I mentioned earlier that there is a high comorbidities between depression and anxiety, and I thought to illustrate the potential why there is high comorbidity is using this cognitive and behavioral model. So if we break down our internal experiences as human into these 3 categories: thoughts, emotions, and behaviors, with the case of Charlie, for example, the case example I mentioned earlier today, here are some difficult, intrusive, scary thoughts that Charlie reports. I will drop my baby will stop breathing, I am failing as a mother, baby doesn't love me. Sometimes some parents report that they think that babies can easily be soothed by other people than the mom or the parent. Another common thought is that my doctor doesn't care. So if you just look at this type of thoughts, this difficult thoughts, it could occur within the umbrella of both anxiety and depression. Emotions, the second box, often the different big emotions that we experience as human often occur simultaneously. People often feel both depressed and sad and feeling very irritable and anxious or angry at the same time. We just illustrate here some of the big emotions that perinatal individuals often report. Here are some of the behaviors that we may start to notice among those who suffer from PMAD, some parents may avoid holding their baby. Compulsive checking, whether baby is breathing, if they are asleep, social isolation, or even disengaging. So sometimes with a high feeling of depression and sadness and emptiness, they may really struggle to connect and attach to their babies. Avoid caring for baby for many reasons. Some may feel highly anxious that they're not a good parent, so they are afraid they're going to drop the baby if they carry them certain ways. So as a result, they stop caring for their baby and ask for more help. On the flip side, many parents, if they feel that they're not a good enough parent, this big thoughts may lead them to feeling very, very hesitant to actually ask for help when they need to. They might want to really prove that they are good parents, and as a result, they are hesitant to seek for more help. I really, really like this book by Dr. Kleiman, Wenzel, Waller, and Mandel, Dropping the Baby and Other Scary Thoughts. So Dr. Wenzel also published another book with her colleague on the cognitive and behavioral therapy for perinatal distress. And in this particular book, they discuss some common scary thoughts, and they broke it into this 5 categories. The first one is rumination, where parents might continue thinking about problems or events in the past that happened, and then instead of problem solving, they just continue to think over and over about these problems. Parents may have excessive worry about the future and how they parent their kids, some obsessive thoughts that are intrusive and repeatedly occur in their head. It could also be intrusive memories. So some parents who went through traumatic birth, for example, might continue to think about the event, emergency C-section, or any other events that may be traumatizing that they experienced in the past. And then the last one is this catastrophic misinterpretation of their bodily sensation. So a lot of physiological changes during perinatal period. Those with anxiety might misinterpret something that they experience. A mother may wake up in the morning and didn't feel their body moving, and they might interpret that something is really, really wrong with the baby, whereas other mothers might experience the same thing and just think that maybe the baby is sleeping. So the next thing that we want to talk about is the treatment part of it, which is PMAD management. And PMAD management is defined as the provision of behavioral health assessment and intervention. And the intervention part may include psychotherapy as well as pharmacotherapy for perinatal individuals. So what are some current recommendations that we know out there for PMAD management? There are these 3 major areas. The first one is the importance of screening and assessment. And one thing I want to point it out here is the recommendation currently is to screen at least once during perinatal period. Best practice would recommend multiple time points to screen for PMAD symptoms, because we do know that mood and anxiety disorder don't just occur during postpartum period. So it will be important to screen for the symptoms even during pregnancy, and maybe increase the frequency of screening when there are positive results. The second recommendation is to increase frequency of visits when elevated symptoms are identified. And for those in general healthcare, to refer patients to appropriate psychotherapy or pharmacotherapy resources. So here are some evidence-based psychotherapy for perinatal mood disorder that we know. I actually want to start from the 4th bullet point. There have been studies showing that interpersonal psychotherapy, or IPT, is right now having a really good support for perinatal mood and anxiety disorder. We're not going to talk about all of these interventions. More recent literature also shows that mindfulness-based therapy starts to be examined more in the field for PMAD. We are going to focus mostly on the first three in our presentation today. So CBT for PMAD, and then within that CBT umbrella, we are going to focus on behavioral activation to address depression and low mood, as well as exposure and response prevention to address perinatal anxiety. So I just want to give an overview. Majority of you might already be familiar with cognitive and behavioral therapy and what are some of the core components of CBT. So similar to the core components of CBT for other populations or diagnosis, the highlight that I want to mention for the core components of CBT include the full integration of cultural responsiveness approach, which I'll discuss further after this. The importance of assessment and measurement-based care, and assessment can include clinical interview and diagnostic interview. It could include collateral information. It could include standardized self-report measures or screening measures that we give to patients to identify their symptoms. And with the CBT core components, the first few sessions, if it's an outpatient setting, usually focuses on this assessment as well as psychoeducation of PMAD. And then here are some of the core components we're going to talk about today: behavioral activation, exposure therapy, and relapse prevention. I do want to mention it for this particular presentation, we're not going to go through all of these interventions in a lot of detail. So we're just going to provide high-level summary. So in terms of cultural responsiveness and intersectional approach, there are different models out there to use and guide our ability to consistently implement cultural responsiveness and humility. I put an example here, the work by Pamela Hayes, the addressing model that includes the different intersections that may contribute to how an individual experiences PMAD, and this includes identities such as age, disability, religion, social status, sexual orientation, indigenous heritage, and national origin, as well as gender identity and expression. Dr. Hayes in 2009, so after she published this article, also published another article that includes kind of the 10 steps to implement cultural responsive psychotherapy when it's integrated with evidence-based practice and cognitive and behavioral therapy. So in terms of assessment here, I just summarized the different type of available standardized self-report measures out there, and then the number of items that each questionnaire has, approximate time to complete, and then what type of domains that they're assessing. The EPDS is a commonly used assessment out there for perinatal individuals and their partners. And then there are some measures that require copyright, but also there are some assessments that are free for public, like the PHQ-9, for example, is a very popular one. I also included some anxiety scales that are available out there for the different diagnoses. So when we talk about measurement-based care, I just want to quickly highlight that it includes administering those standardized measures across time. So not just one time, but at multiple time points. So this is just an example of a quick inventory of depression symptoms. You can see that it is implemented at multiple time points. And what's important is to review the outcomes or results that patients report and incorporate it into the treatment planning. So if we're using quits or the EPDS, maybe we start, at 6 months during pregnancy, and then assess it again right at birth, and then, a month or so after birth at well-child visit, and then 3, 6, or 1 year after birth. So here is a model that I want to share on the CBT model of PMAD. I also want to mention that this is not the only model. This is the typical traditional CBT model that I adapt for PMAD, but Dr. Wenzel also published a specific model for PMAD that we're not going to cover today, but I would like to point you to that resource as well that she did publish with her colleagues, another model of PMAD specifically. So in this model, typically we want to discuss with our clients or patients what are some potential triggers to the experiences of PMAD. In this case of Charlie, I just put having a baby during the COVID-19 pandemic. And that this experience then leads to some responses. And these responses include, the red one is emotional responses, sadness, overwhelm, anxious. And then the blue one is cognitive responses, big thoughts, scary thoughts that are related to anxiety and depression. I'm failing as a mother. What if I drop my baby? And then the blue one, the green one is some physiological changes that happen after Charlie had a baby. And as a result of this natural common response, I should stop and say that it will be very important to validate that these responses are understandable considering the stress that patient is experiencing of having a baby in the context of a pandemic. So this validation skill is very important to be implemented when we're talking about these responses. And then we want to further assess what are some behavioral responses that patients experience when they struggle with this cognitive, emotional, and physiological stressors. So some of the behavioral responses that Charlie experiences is decrease in engagement with baby and social interactions, and then increase in avoidance behaviors, isolation, ruminations, as well as some compulsive behaviors such as checking or researching. So here I just want to pair the model with the recommended intervention. For natural responses, the cognitive, emotional, and physiological changes, some of the evidence-based interventions that we know exist may include just symptoms monitoring, increasing more awareness of how these moods and anxiety impact their avoidance. We may also want to teach some mindfulness or paced breathing and deep muscle relaxation. For some, they may benefit from some thought reappraisal or thought challenging intervention, and emotion regulation and distress tolerance can be the intervention selected to support patients in this natural responses. For the presentation today, we're going to focus on how we address the behavioral responses through BA and exposure and response prevention. So when we talk about behavioral activation and interventions in general, it will be important to understand our patient's values. BA is simply defined as the goal of BA is to help our patients achieve a meaningful life filled with diverse and stable sources of positive reinforcement, and that the goal is to slowly and gradually help our patients re-engage in meaningful activities that are aligning with their values. So what we mean by diverse sources of positive reinforcement is that we don't want to put our eggs in one basket. It is very natural and understandable that for a new parent, their eggs for some time may need to be put into this one family and parenting basket. While it is understandable, it is also important to balance when it is feasible, to then schedule some activities that patients may avoid due to anxiety or depression, such as self-care or social interactions, or hobbies. So the goal of BA is to gradually help our patients distribute the how they spend their time, so then they can get diverse sources of positive reinforcement. So with behavioral activation, typically we want to create what we call BA hierarchy. And our BA hierarchy, if you look at the activity type column, should include a diverse type of activities. And this may include healthy routines, but also pleasurable activities and then value-guided activities. So in this example, we include things like taking a shower, eating, calling best friend for 20 minutes once a week, and then mindfulness while nursing the baby. And then we ask our patients to rate their level of difficulty. What we want to do here is to start with some activities that are a 3 or a 4, so not too easy that they won't feel accomplished when they do it, but also not too hard. And then gradually increasing more diverse type of activities. With exposure, two main part of exposure is exposure itself, or repeatedly and systematically having our patients face an object or situations that they are afraid of. And at the same time, supporting them to refrain or resist any compulsions, avoidance, escape, or safety behaviors. So checking and researching might be an example of safety behaviors, or asking their partner, am I a good mom, when they're holding their baby. With exposure therapy, what we want to do is helping the mom to hold the baby while resisting asking their partner whether or not they're a good parent. So here's just an example of how the case conceptualization of exposure therapy. With holding the baby, they may start to experience a lot of this difficult thoughts. I will accidentally drop my baby. I will trip if I hold my baby while walking. So these are just some, and then they'll feel anxious and overwhelmed. So their responses to holding the baby, and as a result, there is a decrease in spending time holding the baby or going anywhere outside. And then more reassurance when they're holding the baby. So with exposure therapy, there are 3 things that we typically do as an intervention. So one is in vivo, or having the patient actually holding the baby either in treatment or as part of homework at home. The other part of exposure is imaginal exposure. Maybe a parent will be asked to write down or imagine holding a baby and accidentally trip. And then the third part of exposure is what we call interceptive exposure. So sometimes somebody can get really sensitive to the physiological reaction that their body experiences. So we want to mimic those sensations, for example, by running up and down the stairs or swirling in a chair to kind of have them get used to this physiological experiences. Similar to BA, with exposure therapy, we also build exposure hierarchy. So you can see an example of exposure hierarchy here. Traditionally, we encourage patients to start with something that is a 3 and a 4 and gradually increases. More recent literature starts to look at whether or not that is the most important, or if there are any function in not just following that gradually always all the time, but kind of mix it up depending on what functionally is the most appropriate for patients. All right, so with exposure treatment, what we want to do is this red line is where we start the exposure, for example, holding the baby. And we know that anxiety will go up It's important then when anxiety is at the highest peak that the mom doesn't ask, am I a good mother? And then the idea of exposure is if she can hold the baby for some time without doing safety behaviors, then gradually she will reach what we call habituation, and anxiety will go down. So, if we do repeated exposures, then the idea is throughout time, anxiety will not peak as high, and then habituation will be achieved faster. I do want to highlight one more recent research here. Traditionally, habituation has been proposed as a big component of exposure mechanism of actions, but more recently, Michelle Kraske and colleagues in 2008 did look at different studies and concluded that the central mechanism for exposure not always necessarily occurs through habituation. Some patients may not experience a reduction in anxiety, and what's important is their ability to tolerate the distress and anxiety during the exposure itself. Okay, I'm going to switch it to my colleague now, Dr. Rajanna, for the next section.
Hello, everybody again. So that was a wonderful presentation about all the symptoms and illnesses that we struggle through pre-pregnancy, post-pregnancy, so much we go through without being pregnant. On top of that, if we have to go through pregnancy, irrespective of what support system you have, you don't have, you are struggling. So knowing that this is going to be a crucial moment, and I've made a choice because I wanted to, or I did not want to. Now I'm in it. So then what do you need? I think the support system that Dr. Puspitasari talked about is very, very important and crucial, because that already kind of gives a sense of support to the mothers and the group of people who are trying to have a baby and raise a baby. Now, with that, sometimes that is enough to help these women struggling with the symptoms, but there are some situations or illnesses that need more than that, and that's when the medications come into picture. So during pregnancy, obviously, I want to highlight and say that neither medication or no medication or minimal medication are recommended, considering evidence-based research is very, very minimal in pregnant women. We cannot do any type of randomized controlled studies for pregnant women. Basically, it's illegal to do that. And the first trimester of pregnancy per se is very crucial because the organ development is happening. So we tend to tell women not to take any type of medications, including Tylenol for that matter. So any studies that we have so far are mostly retrospective studies, because we went back and looked at what women have taken during their pregnancies and what type of impact that has had on the women per se, or the infant or the fetus later in life. So most of them are retrospective. I also want to emphasize that while concluding the results from these type of studies, we have to be very careful as to what we infer from it, because there are so many confounding factors that we are not looking at that could be contributing to those type of results. So something to think about. We always have to consider risks versus benefits for the mothers and the impact on the newborn in that process. Next slide, please. So there are a few categories that we have divided into to understand the medications that we are going to utilize in pregnancy. So the categories include category A, which is obviously adequate and well-controlled studies are there that have failed to demonstrate any type of risk in the fetus in the first trimester, or there is no evident risks in the later trimester. That is category A. Category B, animal reproduction studies have failed to demonstrate any fetal risk, but there is no controlled or adequate studies in pregnant women per se. Category C is about animal reproduction, has shown some adverse effect, but and there is no adequate study in the human studies, but the potential benefits may warrant the use of drugs in pregnant women despite potential risks. And category D is there is positive evidence that there is risk in human fetus when utilized, when these medications are utilized, but the potential risk may warrant the use of drug in women than the risks per se. And when it is X, we know for a fact that we will not be using that medication because the potential, the benefits don't outweigh the risks on the mother or the baby. Next slide. Thank you. So obviously we tend to utilize the medications based on these retrospective studies that have been done. We do have the antidepressants, anti-anxieties that we tend to use. More so, even in OCD symptomatology, which is serotonin-based illness per se, we tend to use SSRI as the primary drug of choice. SSRIs are mostly pregnancy category C drugs, except paroxetine, which is categorized as D. More frequently used SSRI drugs are sertraline and fluoxetine. Paroxetine, on the other hand, we don't use in pregnant women, but we can use that safely in breastfeeding. The antipsychotics and the mood stabilizers are also cautiously utilized based on the need of the mother and how that can impact the baby if we don't use those medications. Mostly we tend to use older psychotropics which have more evidence considering they've been used the longest. Haloperidol is one of those drugs. They are mostly the typical antipsychotics. High potency drugs are mostly used versus low potency drugs. We do have some evidence to some of the atypical drugs like Seroquel and Zyprexa, which are being utilized a little bit more in our practices now. But we have to be mindful about the metabolic syndrome those drugs can cause. Depakote and lithium are definitely not recommended due to documented teratogenicity in the newborns. Next slide. Thank you. Pregnancy outcomes, when we do utilize these medications, we tend to see teratogenicity, which is cardiac defects or cleft palate or organ dysplasia. There could be spontaneous abortions, hypertensive disorders, postpartum hemorrhage, preterm birth, low birth weight. We also have to think about if there is benzodiazepine use, the baby born might have withdrawals or sedations that the newborn can experience. We have to be mindful of all this. Next slide. So with that, I want to say what is important is to make an informed decision. And that is the key to how we proceed with this delicate situation of pregnancy, mental health, and having to have medications as a part of the treatment. Making sure that we guide the couple and the family in making the decision of what best medication choice that they can do, the dosing, the duration of usage. Some medications could be utilized in the second trimester versus in the third trimester. We want to back off to prevent postpartum hemorrhages and things like that. So being very mindful about that. So we are using these medications to balance the severity of the illness, and also if they are chronically ill, that we are trying to make sure that we are reducing the impact eventually. Next slide. And stigma is another very important thing that we are trying to help address with our patients. There is already mental health stigma on top of that for pregnant women, that they have to be very mindful of the medications that they're using, because there is stigma on that as well. So we have to continue to educate the family members, support them to support the mothers. And also multidisciplinary approach is something that is going to help ease the pregnant women and their families, that the providers are together trying to help through this process, whether during pregnancy or post delivery, so that the decisions are made for the well-being of the mother and the child. Next slide. Thank you.
I'm gonna finish up the rest of the presentation. Now we're gonna talk a little bit about the barriers of accessing care for PMAD. Unfortunately, right now we know that half of perinatal women with the diagnosis of depression and anxiety do not get the treatment that they need. We also know that only around 50% of clinicians routinely screen for PMAD. And some of the barriers that they report include lack of training, and then they are ill-equipped to know what type of interventions or how to provide referrals when patients do endorse PMAD symptoms. We also know that even though patients prefer psychotherapy to help manage their PMAD, that 75% of perinatal patients only receive psychopharmacotherapy. In this study, they looked at some of the survey why that the clinicians who treat women and individuals during their perinatal period, they reported that about 34% of them never received PMAD training in the past, and that 66% only had about 10 years of had less than 10 years of experience. And that 47, almost half of the clinicians reported that they provide PMAD management to less than 30% of patients with PMAD. 40% reported that they don't do screening routinely, only when the patients express PMAD symptoms. And this on its own can be a challenge because many parents may be hesitant to report and share that they are experiencing PMAD symptoms if this is not part of the routine screening process. Some of the barriers to implement PMAD management include, from the patient level, includes the stigma to seek behavioral health care. Some individuals may have limited insurance coverage, and that's why it's really hard for them to access PMAD management. We also know that specialty PMAD care is very limited throughout this country, especially when it comes to higher level of intensive care, such as partial hospitalization and intensive outpatient. So there may just not be available services in the area for these patients. There are clinicians who report that they have negative attitudes towards screening PMAD throughout a perinatal period. And like I mentioned earlier, that there's a limited access to specialty PMAD care. So in this article in 2017, Kandick and colleague put together a list of recommendations for systems and organizations or clinics on how to implement PMAD management. The first one is, again, we know that many clinicians did not receive specialty training in PMAD, so having organization provides more training and supervision for clinicians could be beneficial. And then engaging relevant stakeholders. So if your practice decides to screen for PMAD more routinely, to have buy-in from all stakeholders, to establish and provide training on what it means to provide a culturally responsive, trauma-informed, and gender-affirming environment, to identify and implement PMAD tools, educate clinicians on measurement-based care and how it can improve the selection of interventions and referral process, provide PMAD psychoeducation to those who may be affected. So even in primary care settings, pediatrician settings, providing handouts and patient education materials. And then also very important to highlight is to activate emergency protocol if parents do report increase in suicidal ideation or homicidal ideation. That is the last slide that we have for this presentation today.
Thank you. Thank you so much. We do want to answer some questions right now, and I have been seeing some of those questions come through. If you have a question, please use the Q&A button, not the chat feature on the Zoom task force. We will try to answer as many as we can in the time we have left. We may also combine just some similar questions submitted. If you've asked similar questions, just so we can get to everybody's questions. If we don't get to your question, please send an email message afterwards to webinars@rogersbh.org, and we will follow up. So some of the questions that I have seen coming through, one of them I thought I'd start off with is, can you speak to the timing of involving support persons in the care of an individual who is experiencing PMAD? And this is kind of a three-part question. So at what point do you think you engage the support person in the therapeutic process? And third part of the question, what recommendations do you have for enlisting support in individuals who do not identify as having a support network, whose network may have been disconnected from them?
I can take this one. So my recommendation will be to engage this conversation very early in treatment. And I think it's just best practice in any psychotherapy to ask the patient if they have identified any social support or emergency contact that they would like to include in the therapy process. I think one thing that will be important to keep in mind with increased depression and anxiety is that risk of increased suicidal ideation and homicidal ideation. So best practice is to include, with the patient's consent, to include a support person early in case the patient needs more support to use their crisis management tools or to practice other skills that we are teaching in therapy. So that would be my recommendation. Dr. Rajanna, do you want to take the other part, or do you want me to keep going?
I agree. I think the earlier the better. The sooner the better is what I would say. That usually, there is a lot of hesitance to even reach out. So when the mother reaches out, I think right away that they need that support system. And there are so many, nowadays at least we do have multiple groups that are happening, parental teaching programs that are happening. I think we should start kind of introducing those to parents who are struggling with having the support system. I think that would be helpful.
Yeah, I like that. And just one thing to add, in addition to support group, I think it's important for, Dr. Rajanna mentioned it earlier, for interdisciplinary team members to have a collaborative care models. So even if their social network is limited, if the social worker and pediatrician and primary care could, and the therapist could engage in warm handoff, I think that would be important to have all interdisciplinary team members in the loop.
Great, thank you. Another question we have here is, what specific information do you look for to help you differentiate intrusive thoughts or harm towards an infant from actual risk of harm behavior? And how do we determine when to contact social services or the like?
I think that's a very, very important question, that we understand that we don't cause false alarms yet. We need to be very, very mindful of the danger to the baby. So if you're noticing any obvious bodily harm on the baby, if there is bruises that you're noticing, if the baby is behaving a certain way that is not appropriate for that time or the age group, that we need to be looking at calling for help. Getting some collateral from the family members is also helpful. I would do that before I jump to conclusion, to try and understand. Some of it probably was within the normal limits. To know that I think is crucial as well.
Great, thank you. And then here's another good question. Where do I find specific resources related to transgender youth and PMAD? And do you know of any support groups?
Yes, that's a really great question. So I think, as I mentioned earlier, the research specifically on transgender and perinatal population is still very limited. I personally don't know any specific resources for transgender and perinatal population. However, there are local groups that for transgender youth and adults. For example, I'm based in the Twin Cities. We have some gender clinics who also provide support groups. The other thing is we also have here in the Twin Cities specialty perinatal programs that also offer support groups. And those might be a first resource. I'm also happy to do more research that I may not be familiar with, and maybe we can include more resources if I can find more. I don't know, Dr. Rajanna, if anything comes to mind.
I think the ones that you mentioned are the ones that I'm aware of, but we can look into that and probably provide more information on that.
Great, thank you. And you guys also spoke to the social isolation as being a factor that impacts adolescents in particular. And what strategies do you use to increase social connectedness for this group of patients?
Yeah, I think, like what we discussed earlier, is identifying social support of choice early in treatment. This may be parents, this may be partners, this may be other, adult supports that they identify to include. The other thing is any local resources that, like parenting groups or any other type of groups that they may be a good fit to join. I think tailoring it individually and as part of maybe behavioral activation hierarchy building or exposure hierarchy building to identify different circles. If part of their low connection to social support is due to depression or anxiety, then they may put in their hierarchy some people who they feel more anxious to engage with, but will be important to be included in their social support, and those who they feel more comfortable to start building more frequent communication or connection with. So I think incorporating it to the treatment plan will also be very important.
Great. Another question that we've got here is, some of the thoughts expressed in your clinical examples sound like they could be postpartum OCD. Can you suggest ways to differentiate PMAD from postpartum OCD, or is there overlap?
You want to take this on, Dr. Rajanna?
Sorry, I missed a part of it. The voice was not clear. Can you repeat the question?
Oh, yeah, certainly. Can you hear me now?
Yes, yes.
Okay. Some of the thoughts expressed in the clinical examples sound like they can be postpartum OCD. Can you suggest ways to differentiate PMAD from postpartum OCD, or is there overlap?
I would like to say there is definitely overlap. There is a possibility of OCD-like symptoms that kind of gets becomes more prominent in postpartum women. Yet for people who already have OCD, kind of gets exacerbated during postpartum time frame as well. Most of the symptoms overlap, so it is very hard to differentiate which is which, but they are mostly surrounding the baby care more so that we tend to see with pregnant women when they struggle with those OCD thoughts. So yeah, they mostly overlap is what I would say.
Okay, thank you. Some other questions we've had are related to COVID. Have we seen an increase in PMAD symptoms, during COVID? Is COVID attributing to that at all?
Great question. I am not familiar. I haven't come across any study looking specifically at that. Again, I may miss because it's going to be very recent literature. So just like with any other symptoms, I think some studies have documented that there are increases in suicidal behaviors and depression and anxiety. But I don't know any specific study that comes to mind that has looked at it.
I completely agree. I mean, we are too early on in this pandemic and the post-pandemic phase that we are trying to learn as to what the situations have been. I think we are yet to kind of go back and look into that. We don't have anything that is out there just yet for us to refer. But definitely in my practice, though, I have seen quite a bit of struggle with women, particularly with OCD symptoms. Anxiety disorders have increased with the ones that I have been seeing in my work, but we don't have any studies that kind of support that. Larger studies, I would say.
Thank you. You identified poor attachment with baby as an adverse side effect of PMAD. Do you recommend including the infant in therapy sessions to practice behaviors that improve attachment?
Absolutely. I think when it is guided by the clinical case conceptualization. So I'll use an example of perinatal OCD. If the mother is really afraid that she's going to drop the baby, part of the in vivo exposure may include holding the baby during treatment. So if the mom is willing to have the baby join part of psychotherapy session and the therapist engaging in vivo exposure with the mom maybe starting to hold the baby while sitting and holding the baby while standing. The other thing with poor attachment is with the mindfulness exercises. Sometimes we do invite mom to bring babies. In my past practice experiences, we invite parents to bring their baby and practice mindfulness while looking at the baby's eyes and holding the baby. So the answer is yes.
Great. And then, at what point do you decide to refer for a psychiatry consult?
I think I'll take that one. Like I mentioned earlier, I think support system, CBT, DBT, and the not DBT, sorry, CBT and the supportive therapy is very, very important and crucial with pregnant mothers and postpartum. When these treatments are helping but not enough, or that the illness itself is so severe that we have to add medications to it, is when we are considering psychiatry as a referral base. But I would also say the sooner you get a psychiatry referral and a consultation, it's always helpful in future as to how it transpires. So when we can start the medications and things could be considered at that point rather than waiting till the last minute. So I would say the psychiatric consult is helpful just to have a baseline as to where things are and how they progress eventually, and when the medication intervention has to be done could be decided by the psychiatrist eventually.
Great, thank you. Some additional questions that we have here are, we know that hormonal shifts can be a major cause of postpartum mood disorders. Do we have any research on if this is similar for those with perinatal mood disorders?
Perinatal mood disorders, yes. Without any pre-illness, people develop, purely during their postpartum or around pregnancy, these symptoms which kind of last through the postpartum, and then eventually kind of they tend to get better with the illness. Sometimes it's a cyclical illness in itself and it passes. And when you wait for it to pass, obviously there are lots of things that can happen, and that's when the treatment becomes crucial. Yet if somebody has already had those symptoms and we're struggling with those illnesses, it gets exaggerated in the postpartum time frame. So we have to be mindful of both as to how much support, how much treatment, when medications are indicated, and when it is therapy and support that is necessary. So we have to be kind of thinking about all of those aspects.
Okay, thank you. That's all the time that we have for questions today, everyone. I do need to get you to some additional resources and close it up for the day. But remember, if we did not get to your question, please feel free to send an email to webinars@rogersbh.org, and we will follow up with you. Many thanks to each of our presenters here for taking time away from your clinical practice to share your valuable insights with us. We know that collaboration is essential to helping a patient on their road to recovery. Rogers provides services throughout a growing network of communities across the U.S. and other multidisciplinary treatment teams, and we're ready here to partner with you. Our outreach representatives are looking forward to learning more about your practice, and we're happy to answer any questions that you may have. And before we conclude, I'd like to ask our presenters to share a few recommended resources on the topic with our participants.
Yeah, so here are just the two organizations that we would recommend if you need to look at additional resources. So ACOG, the American College of Obstetricians and Gynecologists, as well as ADAA are the two excellent resources.
Thank you. Well, that about wraps it up, everyone. I just want to remind you of a few things. Those of you who meet the required time commitment will be eligible for CE credits. Within the next 30 minutes, you'll receive an email with a link to your personal dashboard on ce-go.com, where you will be able to access PDFs of the PowerPoint slide as a handout and complete your list of references. Those of you who met the time requirement to qualify for CE credits will need to complete the evaluation to download your CE certificate for the event. If you have any questions about this, follow up with an email. Please contact us at our support, which is ce-go.com. So on behalf of everyone at Rogers, we look forward to partnering with you to help you support your patients. Thank you so much.